Hello, my name is Dr. Guy Peryer, and I present these research findings on behalf of the DACHA study team. The DACHA study is looking at developing a minimum data set for care homes. The study is funded by the National Institute for Health and Care Research. More details about this presentation can be found by following the QR code to the Age and Aging paper published earlier this year. And below that is a link to an editorial the journal wrote about the paper that also may be of interest. In this slide, I'll talk about the motivation behind the review. It's fair to say that implementing research trials in care homes is extremely challenging. In the past, research hasn't always gone to plan, and this review aimed to understand if there are common themes of what can go right and what can go wrong, so researchers and care home staff can be more informed about what to expect and what to prepare for. Between 2013 and 2020, the NIHR funded 5 multi-centre cluster randomised controlled trials, and the total amount awarded was over £8.5 million. All of these studies produced neutral findings. After working on one of the phase 3 trials that is included in the review, I was interested in how much the delivery processes of trials in care homes mediated and mitigated the intended outcomes. And as a consequence, if we could say with certainty that the trial was a fair test of the intervention. To consider these contextual factors that can influence trial processes, it required us to analyse process evaluations that are conducted in parallel to the efficacy and effectiveness evaluations. Here are just a few quick points on the methods we used. The protocol was published with Prospero and is cited in the open access paper linked at the start. We included 33 process evaluations from care home trials conducted around the world. We used a best fit framework approach to synthesize the extracted qualitative data. To acknowledge the complexity and heterogeneity of care home settings, we aim to identify an appropriate adaptive systems thinking model to code the data against. Once the data had been coded against the framework, we performed a thematic analysis in order to derive recommendations for future care home trials and to enable us to generate resources that can be used to enhance collaboration between research teams and care home teams. We identified the SEEPS model as having the best fit. On the left-hand side of the image, you can see that it includes a series of work systems that can influence both care home processes and research processes, and also how these work systems influence collaborative working relationships. The SEEPS model is derived from human factors literature, and the person work system is central to the interaction with all other work systems. The activities that the research team and the care home team undertake individually and collaboratively are associated with both desirable and undesirable outcomes. Using this model, we aim to explore how research trial processes have been reported to influence these separate work systems. We were particularly interested in studying how the intervention affected the context into which it was introduced. Now, this slide shows the framework in full. The SEEPS model was developed further to reflect the content of the process evaluation data. We added subcategories to the work systems to formulate a comprehensive framework. It has 28 context domains spread across the 5 work systems, an additional other category that captured data relating to facilitators and barriers associated with the research team and the research process. The framework had 3 levels: the work system, a work system subcategory, and then the context domain underneath. And the extracted qualitative data from the process evaluations were coded against this framework. This radar plot shows the distribution of the extracted data at the top level, the level of the work system. It shows that the majority of barriers and facilitators were coded against the organization, task, and person systems. All 3 work systems incorporate the social elements of conducting research trials in care homes. And what we found demonstrates the need for more of a relational approach that supports positive working relationships between the research team and the care home team. The next slide is a sunburst plot that illustrates the distribution of data across all 28 context domains. So the 28 context domains are listed in the outer ring, and the size of each of the domains denotes the prevalence in the data set. I'll briefly describe the context domains ranked in the top 3 positions. The most prevalent was in the task work system and was associated with the load that the research activities added to staff work schedules. The main barrier to delivering the trial successfully was the compatibility of the intervention with the existing care home routines. The second most prevalent contextual factor was again within the task work system and considered the limited resources that were allocated to care home staff to participate and deliver the intervention. The third most prevalent factor influencing trial delivery was coded in the person work system. It was crucial that the intervention was supported by the care staff, and if it suggested new ways of working, the staff agreed that it was a beneficial change. Without seeing the benefit to their own work routines or a visible benefit to resident care, the novel intervention tended to lose appeal quite quickly. Lack of time to dedicate to research activities was often discussed. A memorable quote from one of the process evaluations mentioned that research teams and care home management often added tasks to daily work schedules, but tended not to explain what existing tasks could be reduced or replaced within the same time frame. When we categorized the qualitative data against the 28 domains, we performed a thematic analysis in order to derive some recommendations for future work. The first theme was known as procedural drift, which has its roots in safety science. A significant problem identified in the current data was how task-focused activities and staff engagement with them tended to dwindle over time, often coinciding with when the research team decreased active involvement following the trial startup phase. If activities diminish, attention to detail, intervention adherence, and commitment to the entire implementation process weakened. Inconsistencies in data collection often cause research teams to question their reliability. The second theme was about the need for all trials to be set in a learning context. The theme highlights the interdependent nature of the relationship between the research team and the care home team, as both need to be prepared to alter their behavior. It is a reciprocal partnership. The findings highlight a real need for authentic engagement in co-production. This is challenging to achieve. It requires awareness of inherent power imbalances. It takes time and planning and requires sustained effort to be effective. It's also true that staff and healthcare clinicians involved in implementing the intervention were not passive delivery conduits. There were distinct effects of learning over time. This has implications for experimental design. For example, in a cluster randomized controlled trial, a care home that receives the intervention early may not be directly comparable to a care home that receives the intervention at a later stage. There is learning and adaptation in the interim period. Overall, researchers planning and undertaking research within care homes need a sensitive appreciation of the complex care home context. Do not underestimate the disruptive nature of introducing novel research processes to existing care home work routines. Staff who found interventions meaningful in improving care for their residents sustained their engagement for longer. Study implementation is most effective where an intervention is co-produced, with agreed purpose and adequate resources to be incorporated within existing routines and care practices. Similarly, do not underestimate the heterogeneity of organizational systems in care homes. It is advisable to assess the suitability of each care home to a specific research study. Overall, the results of the review demonstrate the importance of including a process evaluation in pragmatic effectiveness studies to enhance the explanatory value of the quantitative data. The thematic analysis and the framework synthesis led us to generate some evidence-based recommendations. These recommendations discuss activities that the research team should consider individually, activities care homes, the care home team should consider individually, and activities the research and care home team should consider collaboratively. For the research team, the main element was to prioritize simplicity, wherever possible, and to co-design methods to ensure research protocols are compatible with the care home's way of working. For the care home team, important details were around how staffing and resource allocation can be sustained over the entire trial duration, as this was a key influence on procedural drift. It was also important to consider internal team dynamics within the care homes, because unless all staff within the organisation were clear and supported the purpose of the intervention, lack of awareness often led to a lack of engagement and consequent protocol deviations. For the recommendations about collaborative activities, it was important to consider more of an ongoing coaching model as opposed to a series of isolated training sessions. But key to everything is the quality and frequency of communication between the research team and the care home team. So the previous slide showed just a few of the recommendations we make in the paper, but as an attempt to disseminate the findings more widely, we designed a trifold double-sided leaflet. This is the front, and it describes some key activities across the three areas of the research team, the care home team, and collaborative activities. As the scale of the leaflet shows, it is the collaborative activities in the center that are critical. Collectively, the results highlighted the need for positive working relationships throughout, starting in the design phase. This is the reverse of the leaflet that has more detail on each of the components. It can be read horizontally according to the three types of activities I mentioned, and it can be read vertically using the separate columns. For example, recommendations to build and maintain positive working relationships, and how data collection and other trial evaluation processes can be simplified as much as possible. Copies of the leaflet are available from me using the address on the last slide, and will soon be available in collaboration with the NIHR Enabling Research in Care Homes teams. Many thanks for listening, and if you would like any further information about my talk or the Dutcher study, please follow the links provided. Thank you.